Hello, everybody. Good morning. Good afternoon or good night for some of you. My name is Cesar Della Biancia. I'm from Memorial Sloan Kettering Cancer Center. And we met last week on Thursday for the first talk that we did on contouring that needed for treatment planning for treatments. So today we're going to focus the session on these items. So I'm going to do a brief introduction just to, make sure that we're on the same page. But then the main focus of the talk now is that we're going to be describing the VMAT optimization method. That I just want to say that we are going to explain one particular method that is the one that Adam Shulman, and I'm going to say developed, and it was developed for this. I mean, that's something that he used, but it was developed for this lecture. So we all kind of follow the same way to plan. But I'm sure if you are already planning IMRT or VMAT, I'm sure you have your own methods, and we can always compare notes. And you can always, as long as you have the good plan at the end, it's very important. But just to give you like a consistent method, so we wanted to have just one. So we're going to start with introducing the concept of IMRT. I'm sure you have heard a lot of talks already. And basically, we can say that IMRT is basically like an advanced method of 3D. So you're gonna get super conformal therapy, and you use sophisticated computer controlled radiation beam delivery to improve the conformality of the dose distribution to shape the tumor. So with IMRT, you will have a lot of more degree of freedom to shape better the tumor, be more conformal, and at the same time controlling more the dose to ORs. So there is going to be a variation of beam intensity within each portal. Again, I'm not going to go into detail because you have seen this. And then I usually incorporates inverse treatment plan optimization, but not always. I'm sure you have talked about this, about the difference between inverse treatment planning, forward planning. And there is a lot of publications in major scientific journals about IMRT or VMAT planning in general since the beginning of. I have a recommendation. This is a book recommendation. It's called A Practical Guide to Intensity-modulated Radiation Therapy. By Medical Physics Publishing. It was done in 2003. You would think that it's a little too old, but actually this is a book that it was written by people from Memorial Sloan Kettering with collaboration with other people, and this basically describes our experience at MSK when we started implementing IMRT back in 1995. Actually, I think it was just the very first IMRT treatment we did. So it goes through every single thing. So it's a good book to read. Here's a little graph that I want to just, as I said before, I mean, you can think that intensity IMRT is like a more sophisticated method of 3D. And then on the left, for example, you're going to have the picture of how you will define a 3D conformal plan. So basically, you're going to have three fields, and they're all going to contribute to that square in the middle. So basically they're all going to have those there. So it's hard to control those in this area, but this is the way that we've been treating. You can use wedges, you can use different bit weighting to control certain things, but you won't be able to shape the dose around. With IMRT on the right, by using the same beam arrangement and using different fluence, different intensity on each beam, you can concentrate, for example, in this case, giving more dose for this field in this area to the target, not on the core, if you think that this is a core, and then a little more here just to treat this area here. And as you can see, most of the dose is going to be concentrated around the target, so you can shape it. So just a little bit of comparison. So just to note the big difference between forward planning or conventional planning and inverse planning. With forward planning, basically the user defines the geometry. You define the gantry, the collimator, the couch settings. You define the collimation, your settings, MLC, blocks, and anything. You basically define the fluence. Basically, you do field weighting, or you can use open fields or wedges. But also IMRT can be a forward plan. And I'm sure you have seen that in previous discussion, how you can do IMRT with forward plan. Basically, you you define manually the fluence that you want for each case. The difference with inverse planning is that the user still defines the geometry. You're still going to put your beams with the gantry, collimator, and catch setting, and you're going to be defining those symmetric criteria, and the side weighting for treatment. And then the optimization algorithm is the one who's going to define the collimation and beam fluences based on these criteria that you did before. So it's very important now to know that instead of you doing this part here, the fluence and all that just to conform, now is the optimization algorithm who's doing that. A quick IMRT planning advantages and disadvantages. Again, probably you have seen in previous lectures before. The advantages is that you're going to have the ability to produce very, very conformal dose distribution plans. You can do dose escalation because you can conform your dose to the target, so you can basically increase the dose to fraction to improve local control, and at the same time you're going to be decreasing the dose to surround the tissue, so you're going to be sparing a little more of ORs using IMRT. Those are the main advantages. Some disadvantages is like the planning is a little more labor intensive. Now with the new treatment planning system, there is a lot of auto planning and all that, and the systems itself, they help you a lot, but still you need to spend more time than a 3D plan. This is a bigger disadvantage is like the extended delivery time, because your MUs are going to increase in general now. Then I want to say the danger is a good thing, but by being too conformal, if you do something very conformal and let's say the patient move a little bit, so that very conformal, you might not treat certain areas that you want to treat. So that's what IMRT, it has a big relationship with the mobilization devices that you use for the patient. You make sure that the patient doesn't move and the patient is well immobilized, because you're being very conformal. So that could be a dangerous thing, but it's a good thing, no? And then you're going to have more inhomogeneous dose distributions. And again, these are things that probably you have seen before, but I just wanted to give like a little introduction before we go and jump to the optimization method. As I said before, here we're going to be discussing this method that was developed by Adam Shulman. He's part of the Rayos, board of trustee of Rayos Control Cancer, and he's a medical physicist in the hospital in Nashville in the USA. So we want to thank Adam for his efforts on preparing this, and also to preparing these VMAT planning guidelines that you might have received already, because those were from, also have contouring tips that we talked the topic before. So because of that, the first thing that I put here, and I want to say, contouring are very important. We're not going to go through that because we discussed that a lot in the topic on last week on December 10. We thought everything is within these guidelines, that it's a document that it was made available to you. And then just a reminder, and this is how we finished the last topic, contouring, perfect contour leads to perfect plan. So we're going to focus on the VMAT optimization method, but remember that everything starts with good contours. Also, everything starts with a good beam arrangement. So a beam arrangement is very important. I mean, IMRT, you have a little more freedom to select beam, but you still need to think 3D, as I put here, because you need to make sure that the beams that you select, either IMRT fields or VMAT arcs, they make sense. So you don't have beams that they can basically interfere or confuse the optimization algorithm when you're planning. So the beam arrangement is very anatomical site dependent. So basically you can have different beam arrangement depending the site that you're treating. If it's a brain, if it's a head and neck. And these are things that you, as an institution, you can develop on your own, or you can, like I said, there is a lot of publications on beam arrangement and type of plans and in the journal. So you can find a lot. So I'm gonna just go through some of them just to give you some idea and suggested beam arrangement. But again, this can change and this can vary institution by institution. So also one thing that you have to be careful or be aware is the laterality. If you're treating a tumor that is on a right side, on the left side, we all know that it's better to put beams on the ipsilateral side than coming from the contralateral side. But that doesn't mean that sometimes you need beams from the contralateral. I mean, and we'll go through a couple of examples. So I'm going to go through anatomical sites. So I'm going to start with the brain. For brain IMRT beam arrangement, normally you're going to be using coplanar and non-coplanar fields. Remember, non-coplanar fields are fields that they have couch rotations. And for brain, we can do it because we know that we're not going to have any collisions between the gantry and the couch or anything. We have more freedom to select that. So you need to make sure that the left and the right, they're all superior oblique. So you don't come with anything inferior because you know that that's going to collide with the patient. In terms of number of fields, actually, it depends how conformal you want to make the plans. For lesions that, this is a suggestion again, that they are close to critical structure, 5 to 6 coplanar and non-coplanar fields are okay. When they're close to critical structure, maybe you need to add a couple more, but you can always work with 5. Sometimes you can do plans with 4 fields, and that's okay. This is, for example, a case that it has 7 fields for a target that is on the right side. And you can see how all the beams are approaching from the right side. You might have that coming from the left, but it's superior, so it's okay. So we're saving and we're trying to not to enter through the contralateral side. If we think of VMAT on brain, it's almost the same concept, except that now you're going to have arcs. And sometimes you're going to have full arcs with couch 0. And then maybe you're going to add a couple of non-coplanar arcs with different couch angles. Again, thinking on the ipsilateral side and making sure now that you don't have to be aware of clearance problems. I mean, you want to make sure that your arcs are going to clear. If, let's say, if you go too posterior and the isocenter was very anterior, the couch is going to be very low. So you need to make sure that the beam can go all the way to 180. But if not, you start a little higher. So for head and neck, again, these are suggestions. If you're using IMRT approach, there is a lot of publication on that the ideal number of beams is between 6 to 9 IMRT field, and then avoid going through the shoulders, not through the shoulder, through the shoulders basically, because the shoulders can be movable, so you want to try to avoid. So this is an old technique that they were actually we were using when we started doing IMRT and MSK. We used 7 posterior beam arrangement. Then we went through. You can use some anterior fields if you have disease more anterior, depending what you're treating. These are variations, and you can choose as many fields as you want, but also thinking that they make sense. Okay. If we go to VMAT for head and neck, you can just use simply 2 full arcs, avoiding the shoulders in the optimization module. So on that, you will have a video how to do that. And then here is just 2 big fields, respecting the machine limitations that you have on especially on the X-size, how much the leaves can travel, and with some collimation rotations just to capture the whole field and also not to be with 0 collimation. So this is an example of 2 full arcs, and you will avoid the shoulders while you're optimizing. Also, another suggestion is like you can use 2 full arcs above the shoulders. See, these are fields that we do the full arcs, but we close the jaws above the shoulders. So they're going to go all around the head of the patient, but not through the shoulders. And then you add 2 or more anterior fields that you can capture the whole, the whole target, and then you're going to stop by the shoulders because you don't want to give those to the shoulder because the shoulders can be very movable. Again, these are suggestions. Also, for example, like I said before, you need to be thinking on laterality. If a tumor is on the right side or left side, make sure that you are aware to put fields or arcs, in this case, on the ipsilateral side. Like in this case, for example, there was a tumor on the right side of the neck. So you can use these partial arcs on the right side, because it doesn't make sense to come all the way here with entry dose. So you're going to be exposing more radiation here unnecessarily. Moving to lung cases, a suggestion for lung beam arrangement is between, if you are using IMRT, you can select between 4 to 7 beams. Basically, an oblique beam through the contralateral lung is always useful. Maybe sometimes you can come like this, but see, for example, here you need to be careful because you have the heart right here. You want to avoid entering through the heart. So you're going to come from here and you're going to distribute the field. So this is an oblique coming from the right side in this case, but it's very, it's still on the left side. Also, you're going to make sure that you have 1 or 2 of core beams just to help the optimizer to get a good dose to the spinal cord. But, that is also, with IMRT, we have more freedom to control the dose there. This is a study that we did in the hospital some years ago when we do audits, and we went back to analyze a lot of plant stand for lung cases, and we found out that the typical beam arrangement for lung cases is 5 fields. But you can tell between 4 and 5 because those are the higher percentage, 36% and 45% of the cases, the planners use 4 to 5 fields. So that's a good suggestion. And if you go to VMAT, which is fine, be aware, like I always said, of the laterality. Like in this case, if you're treating if the tumor is on the left side of the lung, you're going to use partial arcs on the left side. So because it doesn't make sense to go all around the patient. First of all, you might have clearance issues with the gantry moving towards the couch here. So it's better to stay on the ipsilateral side. Prostate cases, again, there is a lot of journals and papers published with different beam arrangement. This is what we at MSK, we did it at the beginning when we were using IMRT, between 7 fields equally spaced around the prostate, because the prostate is right in the middle of the target, so you can do that. Or if you need more conformality, you can use up to 9 fields. If you're using VMAT, which is what most places use now, for this is very easy. You just use 2 full arcs around the prostate, around the whole body, and this is, the parameters of each arc. For pelvis cases, I don't want to go in details, but you can read it afterwards. I mean, depending what you're treating, if it's an anal tumor or if it's a rectal case, or if it's a GYN pelvis IMRT, we have different beam arrangement because we position the patient different. So sometimes the patient are supine, but for example, for rectal cases, most of the time the patients are in a prone position. So, and again, you will be using fields equally distributed around the patient, more or less. And here you can be a little more creative of mixing energy, because sometimes for these cases, if you're treating nodes, pelvic nodes, you know that the inguinal nodes, they can be very superficial. So you might need to use 6 MV energy instead of 15 MV for those fields. But again, this is your preference as an institution. If you go to a VMAT, which is again what most people use in these cases because it's quicker, you just put 2 full arcs around the whole body on a supine setup. And then, for example, if you simulated the patient on the prone position, and like, for example, in a rectal case like this one, that you have the tumor very posterior, you don't have much anterior tumor in the anterior part, and in the anterior part you have the bowel, the bladder that you want to protect. You might need, it's very useful to use this partial arc without going through the posterior part of the patient. But again, that can vary from institution to institution. So now I'm going to go to the optimization process. I don't know if you have any question on this, if there is anything on the chat. If not, I'm going to continue, because this is basically the main.
Can I ask a question? You showed the prostate slide. There is one collimator angle is 90 and one is 0. Why is that?
Yes, that's a good question. That is something that I want to say that's very MSK policy that we have. If you talk to the vendors when you go to VMAT, they always tell you, when you use 2 full arcs, the vendor of your machine, that never use the collimator 0, because the leaves in both arcs are going to be traveling on the same with the same collimation. So the leakage that we have between the leaks can be it can create, the algorithm sometimes can handle that. So they always recommended to collimate each arc like few degrees. For example, variant, if you have variant machine, they always said one should be 30, the other one should be 330. So that in that way, so that you get rid of that interleaf leakage, and the algorithms can handle it better. In our institution, instead of following what the vendor said, doing 30 and 330 degrees, we always follow 0 and 90, just because sometimes the 90-degree, if you have a structures, for example, like the rectum, sometimes you can control more with leaves going this way, and you have the other one at 0 that will go on the other direction to get rid of the interleaf leakage radiation. Does that make sense?
Yes, it makes.
And that, again, I showed you for process, that applies for everything, because, for example, if you remember the picture that I sent you for head and neck with VMAT, you can see here that we collimate these two fields. One is 340, the other one is 20. So it's 20 degrees off 0, which is the same concept, basically. And that will definitely help the algorithm, the optimization algorithm, to not to have troubles to correct for that interleaf leakage radiation. Okay?
Okay, thank you.
Any other question? All right, so let's move to the optimization process, because this is the main part. Again, this is going to be very well described in the VMAT planning guidelines that we send it to you from last talk. Again, this method was developed by Adam Shulman, who just to make planning consistent. So again, you can, like I said, you might already be doing IMRT plans or VMAT plans in your institution, so you can use your own techniques. Of course, like for example, at Memorial, we use kind of the same thing, but with some deviations. But we wanted to have one method so that we can all follow, because you're going to be having some planning challenges cases that you will need to do the plan. So we would like you to follow this method to do the planning. So the way that we start the optimization with these methods, we start just putting lower limits, upper limits to the PTVs and the rings structure. Remember, those are the structures that we talked on last Thursday. So we're not going to go through the details on how to use. So you're gonna, just to see if, first of all, if your beam arrangement makes sense, or arc arrangement, and if you can cover the PTVs without actually doing anything to the ORs yet. So if you have a good coverage from the beginning, that tells you, okay, now I'm going to start putting the ORs subsequently, because you know that the coverage is going to start going down. But then, at least at the beginning, you want to have, or you want to achieve good coverage to the PTV. So you're going to start putting all these PTV lower limits to all these structures that we talked before, like the VMAT PTV, the edges, the corners. If you're using VMAT PTV ORs, like the ones that we said that they take out, for example, for parotid glands, that we take that out. So normally you're going to start with 100% of those structures receiving 100% of the prescription dose, and weighting or priorities or penalties, I don't know, depending on the treatment planning system you use, how you call that, of 200 for PTVs. For upper limits, you're going to be putting 0% of the max PTV, receiving a little, 1 or 3% of the prescription now, because it's going to get a little more than 100%. The same weighting, 200. And for the rings, remember that we talk about rings, like 1 ring or 2 rings. So the closest to the PTV, you're going to be putting a maximum dose of 85% of the prescription, with a penalty of 150. And remember that these rings we created with 3 millimeters away from the PTVs. I have a little graph here that you can see how we set all the lower limits for, in this is a head and neck case with 3 PTVs or 3 dose levels. So you're going to have 3 sets of lower limits. depending the PTV that you are constraining. So in orange, these orange is the 5412, the yellow is the 5940, and the pink is the 6996. And you can see here on the left. You're going to be setting up the upper limits, which is the MAC doses, and then again 5412 and 5940 are orange. Sorry, I didn't change the colors just to make it different. And the pink is the 6996. So basically what you're telling here that, okay, these PTVs, they need to be, very well covered. So the shoulders start here, and the dose is gonna fall off with these upper limits. And the same for the 5940, the same for the 6996. And also I said that we're gonna add the two rings. In this case, we have two rings. See, we have the one in cyan color here, the first ring, and that's gonna be the first constraint we put. And then if you have another ring, you're gonna put it from the beginning. So basically, this is how you start. We're not gonna be putting any ORs from the beginning, just because we wanna make sure that we're covering the targets first. And then we're gonna be using normal tissue objective, the NTO. This is only available on Eclipse treatment planning system. For other treatment planning system, you won't have this, which is okay, because then you're gonna be using the rings more to control the dose outside the targets. And these are the initial parameters that we put. This is the graph that you will see from the system. And basically that's how you will know more details of this when we give you the tutorial videos for the head and neck case and the pelvic case that we did for you. You will know exactly what each parameter means. So I didn't wanna waste too much time here. So basically, these are the starting objectives to PTVs, NTO, and the rings, and you're gonna constantly be making sure that you check how the DVH looks for those structure while you're optimizing. The shape of the curves for the PTVs as well as the rings, they should look the same at the end of the optimization. So if you that's basically your main objective. At the very end, we should still keep the same shapes. For each small and large step in the optimization that you're doing, this optimization process, it's better to pause the algorithm, do the optimization, keep going, but pause the algorithm to do it. So here, just to give you an example of here, you can see how we started the optimization already, and you can see how the PTVs are falling the lower limits and the upper limits as much as possible. Then on the later steps of the optimization, we're gonna tweak and we're gonna fine tune the uppers and lower. But see, you can see that all the targets, the 52, this is the same head and neck case, 5412, 5940, and 6996, they're very well covered. I mean, they're almost there. We will make it better eventually later, but it's good. So, and these are the two rings that you have, upper limits. They're not quite there, but that's something that we can tweak at the very end also. So you're gonna be running these until you see that the algorithm stabilize. So then when you reach that point that the algorithm is stable, I mean, that's it, you got good coverage, then you're gonna start adding the upper and mean objective to the ORs, one by one at a time. So that's very important, because if you start like putting, let's say in this case, you start adding the parotids, the submandibular glands, the core, the brainstem, all together, you don't know what is gonna, because you know that the PTV coverage is gonna decrease and the shoulders are gonna be modified. So you don't know which structure is causing you the problem. You can predict that. For example, we know for a head and neck case that the parotids are the biggest problems, basically, because we spare them a lot and they're next to the target. So you're gonna be pushing these ORs doses until the shoulder of the PTV drops. This is an indication that the OR and the PTV doses have reached their limits in the optimization in that particular step that you're doing. And any additional pushing of OR down, pushing down the OR dose will only drop the PTV more. So you need to know when to stop. So if you see that by pushing more the structure, the PTV is already suffering, you stop right there, because we will be able to later on improve both if you need to. And then when you're done with that structure, you move to the next OR and you repeat the same step. Basically, you rely almost entirely on the mean dose objective for all the ORs that don't require maximum dose constraint. For example, the same case, I want to keep the same case. This is, we were done with the PTV and the rings. We start adding, in this case, we add in the parotid mean dose. As soon as we add the parotid mean dose, you can tell that, especially the 5412, which is the target basically overlapping with the parotid, you can see how it decrease, the shoulder decrease a little bit. So you can tell the coverage is being compromised a little, but the shape is still the same. So this is good. So because we know that we can get up here eventually, so that the shape of the DVH is the same. So that's good, because then you need to know when to stop, because if I keep pushing this parotid, this shoulder will change. Then, for example, when I'm done with the parotid, we can move to the submandibular glands, and it's the same concept. So here we have the two submandibular gland mean doses, and maybe an upper limit. And you can see that is, so we're not quite there, but the shoulders of the DVH, they're pretty much the same as before, as the previous graph that I showed you. So that's good. So we are pushing enough to get the mean dose to wherever we want to get them, to obtain the depending on the limits, and the shoulders of the PTVs are still good. So you can notice here that the PTVs, the high dose PTVs, those shoulders, they didn't change at all. We're almost there. Just because for this particular case, the parotid glands, for example, they were only close to the PTV 5412. They were not close to the other PTVs. The submandibular glands, you can see that they're close to the 6996. So that's why here it changed a little bit, the 6940. But that's reasonable. I mean, and again, we will be able later on in the process to make them better, because we even lose this constraint. And also you keep watching on the optimization view. I don't know if you have the actual doses in your treatment planning system, but it gives you the actual dose. So you can see, okay, I'm already okay. I met the constraint for the parotids, which is 26 gray mean dose. So I'm going to stop right there. Then if I need to tweak it a little bit, I will do it later. So at this point, I said that we are only using mean dose constraint, which are very useful. Do not add points constraint for each OR until further steps in the optimization process. So the maximum doses for critical structures, for example, like optics, brain stems, or spinal cord, are not that critical at this time. For this case, for example, if you're doing a nasopharynx plan, that yes, the PTVs are going to be very close. Maybe you want to add it, but you need to be careful. So don't worry, because these are max doses can be easily achieved on the later steps, step number 3 of the optimization. So we will fine tune that later on. So you're going to be repeating this process for every OR, as we said before, for every small and large step until MR2 level, and this is from Eclipse 2, is reached in the optimization process. Note that the weighting on the PTVs and MTOs should never be touched at this point again. So we're going to keep the weightings as they are, I mean, which was 200. So later on in the process, if we need to make a better coverage because we start adding more ORs, then we're going to start most probably increasing the weight. But don't do it at this point, because that's fine tuning that you can do later on the later steps of the optimization. You can slightly increase the weighting of the rings if you see that the max dose is going too high, for example. That you can do. Because the ring can be easily brought down with the fine MLC adjustment in step 3. The OR weightings, normally we said that we're going to start with 100, but they can be increased only to a point at which the PTV shoulder drops slightly. So if you keep increasing the weight and you can see that the PTV shoulder drops significantly, then go back to the previous weight. Here, for example, this is just how the DVH looks after reaching level 2. This is when we add all the ORs. See here, this is most probably the core, this is the brainstem. I didn't show them all because it was very busy, the graphic, but you can see that the shoulders of all the PTVs, they stay the same. This is we need to work a little bit on this. We need to work a little bit on the higher PTV because those were close to critical structure, but you can see that the 5940 is pretty much there. The coverage is, I'm sure it's going to be very good. So for very difficult ORs, for example, like parotids, we all know that. So extra high dose constraint point might be added to aid in pushing down the DVH for that OR particularly. So that's the only thing we normally, the only structure that I would say that you will use these extra high dose constraint points. When MR3 level is reached in Eclipse, so the MLCs are almost where they will be at the very end, which with using all the control points. So at this point is when you're going to be doing this fine tuning that I was talking before. And this fine tuning, you can fine tune the MLC motion in the optimization to achieve full PTV coverage, which is the main purpose of each plan, max ring doses, not too high, so there is not too much spillage of those around the body, and the max OR doses, the structures that I told you, for example, the optics, the brainstem of the spinal cord, that you want to reach or you want to obtain the max dose limits. This is the time that you're going to add them. How do you do this? There is a little trick that we do in this method that we're going to put like upper constraints along the DVH for each OR with a very high weighting. And I'll show you in a minute a graph on that. For example, for 100. So that's basically just to lock the DVH when you, like for example, for the parotid, you lock the DVH there. So, and when you're fine tuning this will give you an indication when you're fine tuning the PTV coverage, if you see that the curve, so, try to go up of those locking, it means that that is the structure that is ruining basically your PTV. So then you need to start working with both, with the mean dose or dose, you push them up a little bit just to, to make a little more flexible on the parotids, and then your PTV will improve. Again, this is something that you will be doing interactively. So you look at the PTV, but also look at the ORs at this point. If the PTV cannot quite reach the original sharp curve from the start of the optimization, you can drag this anchor objectives, as I called it here, slightly higher so you can achieve the PTV coverage. So, and I have a little picture here where you can see how, these are this is the parotid DVH, and these are the two anchors that we put with very, very high penalty. So just to have an indication, because I'm fine-tuning this curve, so I brought all the way up the PTV 5512, and these still remain the same. That means that the constraint that I put for the parotid, they were fine. But in case that this curve surpass these markers, so you can bring these anchors a little bit. So basically you relax the constraints on the parotids in this case, and then you're going to help the optimization algorithm to achieve the lower limit on all your targets. You can see here how all of them, they are perfectly there. Also for the upper limits, see, we're almost there for all of them, okay? So, and then again, this is done on the last steps of your optimization process. So then at this point, for example, when you want to fine tune maximum or max doses, you can use very high weighting for this. If it's not, again, you need to make sure that you always check what's going on with the shoulders of your PTVs. Make sure if you put a very high, let's say, for example, for the core here, now I want to say, okay, I don't want those to exceed the maximum core dose, or even you want to use the ALARA concept as low as possible. So then you put high weights. If it doesn't affect the PTV, that's great. I mean, the maximum, I mean, at least in Eclipse, you don't want to go more than 900. I mean, normally that's a little excessive, but with 400, 500 is okay. The dosage should be about 2 grade lower than what is desired to be achieved with a weighting of approximately 900. And the weighting can be decreased. The MAC dose can be lower, or additional constraint, you can put additional constraint. Like, for example, instead of 0% of the volume, you can use 0.1% of the volume or 0.2% of the volume. But that's if you cannot achieve the MAC dose as it was. If all this is done properly, you should have a perfect line without need of a second interaction. See, we went through each step here, and we never came back to contour extra structures. We get out to see the distribution, because if you pay attention on this, you have met all your OR structures, mean dose or MAC doses, and your PTV shoulders are perfectly following the lower and the upper limits, then you're done. Most probably you're done. Maybe you need to tweak a little bit at the very end, but most probably you will have a perfect plan in only one interaction. That's what basically this method was developed just to have a consistent process of steps that you can do just to work in one interaction. So, but very important, and I have to emphasize that, and I did it in the last lecture, is you need to make sure that the contours that you have created to help remember all these PTV contours we did, the edges, the maximums, doses, the corners and all that, and all the ORs you're going to be using, the ORs in general, they're well defined from the beginning, and the rings, because you want to make sure that everything is okay. So if that's the case, you're definitely going to be achieving perfect plans. So any questions so far? I know we are close. I mean, it's 12, but actually we started late, so I think it's okay to go over. Any questions so far?
There was a question in the chat. I think it might have gotten resolved.
Okay.
But just asking it in case it wasn't. So somebody asked, why use 200 priority? Is it subjective? And furthermore, is the priority only relative to every other priority, or is there a fixed number they compare to?
Yes. Now, very, very, very good questions. The priorities, they are all, they depend on each other. So if they correspond to each other. So it's not a fixed value that you work independently. They are all correspond to each other. The 200 that we chose for the PTVs is something that with experience, we know that choosing this 200 from the beginning with this method, it works really well. Meaning that you use 200 for your PTVs, and then you use 100, basically 50% of the priority from the PTV for your ORs. Then we said that we can modify them, but that's the logic behind. So priorities are all depending on each other. But again, the 200 is something that it will come with experience. We know that if you follow this method, the 200 and 100 for ORs, 200 for PTV works really well. And then you can move around them. Is that okay? If that's clear?
Yeah, there's a follow-up question. So
Sure.
the same person asked if they can use 150 and get the same effect.
150, yes, you can do that. Of course you can do that. But using with priorities, what you need to make sure is, like, you can use 150, yes, because it's still 50% difference. But using 200 and 100, you have then more degrees to change priorities, and it will help you with the fine tuning at the end. It will be, I know that they correspond to each other, but it's better to have a bigger margin, basically, to decrease or increase the priority. But that's okay. And again, this is something that in your institution, for example, if you're doing already IMRT plans and you find out that 150 are good, then it's fine. But what we did 200 and 100 is just because it will give you a little more freedom to when you're changing the priorities. But make sure that when you think about priorities, they're all codependent, basically. Is that okay?
Yes, thank you for that. And then for anybody else who has questions, feel free to type it into the chat or unmute yourself and ask the question at this point.
I have few more slices to do, and it's just, these are like, as I said before, here I know it's complicated to present the optimization as we did for contours last week on a presentation, as much as many pictures we put on the talk, but it's easy to visualize it if we have like a live planning tutorial. So we created these planning tutorial videos for some sites. There is the first one, the first video is for a pelvic case with nodes and 5 SIV simultaneous boosts, so 5 dose levels. And here you have the prescription details. So this is a pelvis plus para-aortic nodes. And this CT set and art instruction will be uploaded in the Prono software for your planning challenge. And we will review. So basically what you're going to be doing, you're going to be following this technique that we explained to you, that they are detailing these VMAT planning guidelines. Everything is there. You can find everything here on the talk. And then you're going to try to reproduce the plan. So you're going to have a video that we went through everything. You watch the video first, and then you do your plan. But also, you can be creative too. We're not telling you to do exactly as we told you, but because the good thing when we review these plans in the next topics, 18 and 19, one is going to be next week, the next one is at the beginning of January, it will be nice for everybody to share their experience. Like, for example, I was constraining too much the parotid and I noticed this, and then I did this trick to change it. So we want you to follow these planning guidelines, but actually be conscious of also adding your own experience too. But for these two cases, just, start with these guidelines, okay? So we have this video for you to watch first. That we have a tutorial video for a head and neck case with 3 simultaneous boosts. These are the dose levels. And this is a Rayos supraglottic carcinoma that we gave you. We're going to give you the CT set, and we're going to give you the art instruction. They're going to be uploaded in Prono. And this is also be used for your planning challenge. And the plans that you will do following these guidelines, we will review on the next topic. Probably not so much in the next 118 because I have more things to present. But if we have time, we can, if someone did it, we can start going with the presentation, but definitely in the session of topic 19, which is in January 5th. Then these are the 2 videos, video number 1, video number 2 for pelvis and head and neck, that we did following exactly this method that we explained to you, which is very good. But also as an extra, we also prepared 3 more tutorial videos for you to watch. Is an alternative planning method. These are methods that we use at Memorial Sloan Kettering, and these I ask very helpful and amazing planners that we have in our institution. They help with the planning tutorial. And then these are also, they're going to be available for you to watch. So you have a different perspective. You have a different, okay, they're different institutions, they do different ways. But at the very end, the final product, the plan, it needs to be good. It needs to be perfect, whatever method you use. So for the plan challenging, you're going to be using these 2 cases, and you're going to be using the VMAT planning guidelines that we explain in these 2 topics. As an extra for your own materials and enjoyment of watching, we have these other 3 new videos. One is for a breast case. It's a left breast carcinoma with 1 dose level. It's breast and nodes going to 200 times 25, 200 centigrade times 25 fractions. Then we have the same case of the head and neck that you're going to watch in video number 2. We did it with the alternative planning method with the 3 dose level. And then we have another pelvic. This is not the same as the other pelvic. It's another pelvis and parotid with 4 simultaneous pulls. These are the 4 levels of prescription. And this is an anal squamous cell carcinoma with nodal involvement. Okay, so I hope that's clear. I want to reiterate the 2 cases that you're going to be doing the plan is the video number 1 and the video number 2. The other ones are extras. Okay. Any question?
There is a question in the chat. Somebody has a question regarding head and neck cases, asking that if the volume shrinks during the course of treatment, there's a rule of thumb in the case of forward planning that every per centimeter, there is a dose deviation of up to 3 to 4%.
Yes.
But what if they're talking about VMAT planning in such cases? What would be the impact of mass variation up to 1 centimeter?
Perfect question. So basically it's the same rule of thumb. It's basically that will be the dose different if the tumor shrinks. And for head and neck specifically, what you will need to be doing, because now it's a good question, because now VMAT, you're going to be entering through the whole body or through the whole basically neck area. So if the tumor shrink of the patient of the target becomes much smaller, so in those cases you need to start thinking what you do in between. For example, in our institution, we do this adaptive planning in between, but it's an offline adaptive planning. So basically the patient is being treated, let's say, for 33 fractions. After a week and a half, if the therapist can notice if, for example, the tumor shrink, because you can see the mass if it's very superficial. But if not, every week and a half or every 2 weeks, we do a new CT scan. And if we see a big change in volume, more than, like you said, more than 1 centimeter, then we will replan, we will recontour, we will replan, while the patient is still being treated with the first plan, but within 1 or 2 days, we have the new plan for the subsequent fractions. And then we repeat the same thing on the next 2 weeks. That's a good question, because you need to pay attention on that, especially for head and neck cases, because head and neck cases, if they respond very well to radiation, the tumors, they might vary a lot. And then you will be treating things that you didn't plan that way. But it's the same rule of thumb as IMRT, okay?
Thank you. We have another question. According to literature, VMAT has less surface dose than CRT. What are your thoughts, and should we use bolus in cases we wouldn't use for CRT?
Yes, good question too. Yes, definitely. For example, for head and neck cases, you definitely will use boluses only in the areas where you have the GTVs very close to the skin. Also, another, like for example, for breast treatments, that for example, if you use tangents, you might not use the bolus because you can use flash to have perfect dose on the skin. But if you're doing a VMAT breast, you might depending on the energy, normally we use 6 MV in our institution. We always use a 3 millimeters bolus on the whole breast tissue, basically, just to help with the skin dose. But that's a very good question too. So those are details that you need to think also when you move from conformal therapy to IMRT or VMAT, but VMAT specifically, because you lose that a little bit. Of course, you won't do that for a prostate case because the tumor is in the middle of the patient, so no bolus there. But for head and neck, breast, those are the most typical. Or like, for example, like when you're doing a pelvic case with inguinal nodes, you might need to add boluses on the area, on the inguinal nodes. Any other question? For some reason, I cannot see the chat, so I'm relying on you.
Yeah, there isn't another question as of right now. If anybody wants to unmute themselves and ask a question, you're more than welcome to. If you are still typing in the chat. Okay, yes, somebody has another question. According to, considering skin flash and breast, how would you use skin flash and VMAT if you don't have motion management?
No, you can, unfortunately. So when you're using VMAT, you cannot do skin flash. So, but the good news with VMAT, I mean, although you cannot do skin flash for IMRT cases, yes, because you can skin flash IMRT fields. And that's something that you need to consider if you're using IMRT for head and neck, for example. You can do flash in areas that you have, like tangential to the target. But for VMAT, you don't have. But what is also being published a lot in the literature, that in general, when you're using VMAT, because you come through with you have so many control points, and you basically go through the whole body. So you definitely, the skin dose is less, and that's what you're going to be using the bolus, but you don't need to do flash for VMAT, because it will take care of the whole control point, will take care of the effect of the benefit of doing skin flash. But that's something that unfortunately with VMAT you cannot do. Yes, you can use a pseudo bolus. Yes, you can use a pseudo bolus and include it in your body, and then that's actually basically brings it's going to make your optimator think that you have more body. Yes, that's a good technique. We in our institution, we don't use it that much, because we have, and you can also, when you start doing VMAT or IMRT even, make sure that you do in vivo dosimetry for all these cases. Make sure that you check those, especially on the skin or certain points that you want to make sure that the dose, what the algorithm or the treatment plan is telling you, is what you're delivering. But yeah, that's a good technique, the pseudo bolus. Yeah, thank you.
Any other questions?
Again, if you have more questions, you know that you can see in the screen my email address. You can send me an email, as before we did for the contouring session. Okay.
Well, if there are no more questions, thank you all for coming. Thank you so much for presenting, and have a wonderful rest of your days or nights, depending on where you are.
Yes. Have a good day or night, and thank you again, everybody, for participating in this session. Yes. And let's be in touch. I'm very happy to be connected with you guys. Bye-bye.
Thank you, Dr. Della Biancia.
Okay, bye.